So that's a mix you're going to get. Um, okay. That's just room. Yeah. Okay.
Hello, everybody. Good morning. It's great to be here, sunny San Diego, finally. And I'd like to welcome you to the Best of the Research, Innovations, and Vignettes Scientific Abstracts, which is one of my favorite parts of the meeting. They're trying to play me off the stage here. First, a few general reminders. First, I'd like to invite you to see the oral presentations. They're oral research and innovations abstracts. You can find the exact presentations in the HM16 app, but they are among the best of the abstracts submitted this year. And it will be in room 17A from 11 a.m. to 5 p.m. today. I want you to tweet about your meeting experience using hashtag HOSMED16. And then a little bit about the RIV competition. So I've been involved in SHM since 2003, and it has been remarkable to see the increase in volume and quality of the scientific abstracts at this meeting. This year we received 1678 abstracts, which is incredible. And if you went to the poster session yesterday, you can see the quality and the depth of the work that's being presented here. We couldn't have done it without our many volunteer reviewers, so thank you very much for judging our abstracts and judging our poster competition yesterday. I'd like to also thank our RIV section chairs for research, innovations, and vignettes. And finally, to say thank you to our SHM staff for coordinating an amazing amount of work, in particular, Jan Bowman. So for today's RIV presentations, we have one innovation and two research abstracts. And the amazing thing is that all three of the presenters are actually in training. So it's a testament to the quality of the field and the future of hospital medicine. Each presenter will have 10 minutes to talk, and then you'll see two standing mics in the aisles on my right and left. And I would invite you to come up and ask questions after each presenter completes his talk. And then we will end by 8:45 for the rest of this morning session. So I'd like to first call up Sam Panic, who is a research fellow at the NIHR, Imperial Patient Safety Translational Research Center, which is quite a mouthful. And he will be talking to us about a prospective clinical team surveillance project.
Thank you so much for the invitation, and on behalf of my team in London, I'm delighted to report the results of our Heads Up study. I'm sure you know that delivering reliably high-quality care in the general medical ward environment can be extremely challenging. Our patients are elderly with increasing comorbidities, and there's no single best pathway for their diagnosis or treatment. But we also face an operational challenge, which is a challenge that the intensive care unit or the operating room don't have. And the operational challenge is that it's very difficult to get the organizational attention or the organizational resources that we need to resolve frontline care issues in terms of operational problems. And one possible way to get past this is to try to better understand and better use what frontline care teams are experiencing every day. And there's good evidence that our care teams are recognizing issues with how we're trying to deliver care that simply aren't captured in incident reports or in the medical record. Now, a number of studies have now described this system of prospective clinical surveillance, and that involves a trained observer working with staff in their clinical area to try to identify potential problems and potential adverse events. And you can imagine this generates a very rich data set in near real time. but it's never been evaluated in a controlled study, and you can imagine that the requirement to have an observer in each area could be a barrier to wider implementation. Is that observer even required? Well, previous work has shown that with a structure, teams can actually self-report the vast majority of errors that are documented by an observer, at least in the operating room. And we wanted to take this further for medical ward teams, and we did that with the Heads Up trial, hospital event analysis describing significant unanticipated problems. The Heads Up intervention had two components. The first was a structured, daily, interdisciplinary briefing led by any member of the ward team that tried to identify the clinical and administrative challenges of the previous 24 hours. We based the content of the briefing on a large observational European study which described the type of problems that happen most frequently on medical wards. And we honed the briefing with input from clinical staff at the front line during a 1-month pilot period. The briefing tried to identify background concerns about staffing, equipment levels, consulting services, patients who had deteriorated or who had suffered a complication. There was an opportunity for constructive criticism, and then crucially, a decision about what the team could do next in terms of either trying to resolve those issues there and then or escalate them. That was the first part of the intervention. The second part of the intervention was to make sure that that information was disseminated and used as effectively as possible within the institution. And that involves summarizing it, reflecting it back, first of all, to the ward teams who were participating so that they could understand their clinical areas, but also escalating it to their service leads, to board-level executives, safety and governance committees, and also support services. That generated feedback action, which was itself fed back to those teams again to motivate them to continue with the briefings. And we called this prospective clinical team surveillance to try and make that clear distinction that this isn't dependent on an external observer. This is all structured, self-reported data by frontline teams generating this hopeful improvement. We introduced Heads Up in a stepped wedge trial design, and if you're not familiar with that, that involves sequentially introducing an intervention to different areas, different clusters over time, so that by the end of a study period, all of our participating units had adopted Heads Up, but each had had an opportunity to contribute both control data and intervention data. And this is a useful study design in that it allows you to correct for any secular trends, any trends that are affecting all of the units over the study period. We set the trial in a community hospital in London in the United Kingdom with around 50,000 admissions per year, and existing practice included a daily interdisciplinary board round, which was typically focused on patient discharges, and use of the Datix incident reporting system online, and mortality case note reviews. We evaluated Heads Up qualitatively and quantitatively with assessments of safety and teamwork climates using a validated questionnaire, participant ethnography, characteristics of incident reporting, and finally patient outcomes. And our primary patient outcome was excess length of stay, which we defined as a hospital admission lasting longer than 24 hours above what one would expect for that particular patient based on their diagnosis and treatment codes. And we established a group of 4 local hospitals as our comparators, all of whom were subject to the same community pressures. We excluded patients who were being newly discharged to a nursing home, who had undergone multiple intra-hospital transfers, or who had received intensive care, and we corrected for numerous patient confounders, secular trends, ward workload, and the clustering of outcomes by ward. We had a comprehensive data set with over 850 briefings to analyse, 90 surveys, 2,000 incident reports, and we looked at the outcomes for over 11,000 patients with around 6,000 in the intervention group. And the intervention was taken up at the front line. We saw that it was used on 77% of working days per month, and wards were reporting more than 80 issues per ward per month with this system. We saw significant improvements in both safety climate and teamwork climate, statistically significant, with increases of about 10 points on a 100-point validated scale for each of those metrics. 70% of our participants reported their concerns differently due to Heads Up, they told us. They said that they had a much greater understanding of their whole environment. It made them more present. And we saw increases in both non-falls incident reporting and reporting by medical staff. And both of those have been correlated with a stronger safety culture and a stronger reporting culture. The system generated $38,000 in internal investment for quality and safety. And for our institution, that represented a substantial investment. And Heads Up was also recognised by the Care Quality Commission, the UK's National Inspectorate for Healthcare Quality, which declared it outstanding practice, which was its highest accolade. Ultimately, we did see improved patient outcomes. And you can see from this graph, represented best with the dark line, that the units implementing Heads Up best, most frequently, and with the greatest engagement, reporting the most issues per month, saw steady reductions in the likelihood of excess length of stay. And those reductions were both statistically significant and clinically meaningful, with an odds ratio for excess length of stay of only 0.82. This was just a single centre study, and we know that the effects of these complex interventions can be difficult to replicate in other centres, although we have now successfully introduced Heads Up in a second academic centre. There have also been multiple descriptions that in our current healthcare climate, it can be difficult to protect team quality improvement programs like this from financial pressures. But we have shown that prospective clinical team surveillance generated real frontline engagement. It changed individual practice and practice at a team level, and it changed our focus to resolving latent problems before a never event, and this directly improved patient outcomes. Interestingly, these have all been described as key weaknesses in our existing incident reporting systems. So we're not suggesting that prospective clinical team surveillance replace incident reporting, but it certainly seems a strategy to help mitigate some of those very common problems. I think this speaks to a broader future that many institutions are already moving towards, where the focus is moving beyond the single issue quality metrics that we're increasingly burdened by. And we're looking to try and really identify the team structures that help us best in complex environments. We're looking to establish multiple formal information streams, both from patients and staff, to help to identify these latent problems. But ultimately, what we found in this study was that we needed to work harder to align the clinical and the managerial incentives to try and resolve those problems to help both clinicians and managers move forward. Thank you so much for the opportunity to speak to you today, and if we have time, I'd be delighted to take questions.
So there are two microphones, one on each side, and Vinny.
Thank you. That was a wonderful presentation, Vinny Aurora from Chicago. I was really interested to know what led to increased adoption of this intervention, particularly since that was linked to your outcome. And you had some that had very high adoption and some that did not, and whether you're planning on studying that in the future.
Sure. No, that's a great question. I think the take-up was really important, and the implementation model for this kind of intervention is immensely important. It's not something you can simply ask teams to do without giving them an understanding of why it might work, how it might work for them, and actually the benefits that they might see from it. And one of the challenges that we faced was change fatigue, which I think is an enormous problem worldwide. People are under immense pressure to adopt all sorts of initiatives that often come and go, and they are initially resistant to try largely anything new. So that we certainly face that. I think the key to improving adoption at the front line was actually the facilitation. And when I didn't go into much detail in terms of some focus group work that we did at the end of the study, but actually we were told by frontline teams they really valued that. It was the feedback, it was knowing that the information that they were producing was useful, it was being used, it was being heard, and that it was being escalated more effectively than they felt they could do on their own. I think that was the single key factor that really helped the most. But actually feeding it back to them was also really valuable, and I think it increased their buy-in because they knew that someone was paying attention, someone was listening, but it was information that had great face validity for them, because that was actually something that eased the implementation. They looked at this tool and they said that really resonates with the kind of things that we know are happening every day, but we're not able to use that at the moment. But it was seeing that there was a structure, there was an investment in trying to make their voices heard. Interestingly, the organisation at the end of the study, I think, in common with many organisations, felt that this was something that should be able to run on its own, and they were keen to downplay the impact of facilitation. So I think that's something we did have to fight for.
Over here on our right, and could you introduce yourself?
Hi, Jeff Schnipper, Brigham and Women's Hospital in Boston. Very nice talk, and I think it really does have potential to change culture in a way that not a lot of other things have. My question is, it looked like the analysis that you presented was a on-treatment analysis. In other words, those that were more engaged and reported more issues had a reduction in the excess length of stay. Do you have the intention to treat analysis? So looking at all comers, whether or not they adopted this widely, what the impact was on your primary and secondary outcomes?
Yeah, so that's a great question. So I'll scroll back to that primary outcome graph. So you're quite right. So that's a per protocol analysis, or those groups divided out by how they actually implemented the intervention. And we thought that was an important analysis because actually it's very difficult to quantify the effects of these team-based interventions if you don't actually look at who used the intervention and who didn't. And certainly with the surgical checklist work, that's been a major criticism of those studies that have found no effect of the surgical checklist, is that they actually haven't used at which teams have been using the checklist or not. That was certainly a criticism of the Ontario study. We didn't find an overall intention to treat effect, but I think that would be consistent with what one would expect from everything we know about team-based interventions. There are teams that implement this with greater fidelity and those that don't. What I would say is that our statistical model in terms of looking at the cluster controlled trial certainly accounted for existing baseline performance and for the clustering of ward outcomes. And I think those would be the two main concerns about over-interpreting this data. So I think it's a valid interpretation, but clearly we need to work to try and bring as many wards as possible into that high-fidelity implementation group.
Great. Thank you so much, Dr. Panik. Our next presenter is Sajan Patel, who is an academic hospital medicine fellow at UCSF, and he will be talking about his innovations project, the Feedback Bundle, Reimagining Audit and Feedback.
Hello, good morning. I'd like to thank you all for waking up so early to hear our talks. And I'd also like to give you a warm welcome to my childhood home, sunny Southern California. So today, I'll be presenting an innovation in audit and feedback that we call the Feedback Bundle, which we believe can lead to real and sustainable performance change. I'll also describe how we developed the Feedback Bundle and describe the clinical trial we're conducting to test its efficacy. So audit and feedback is everywhere in the real world. From exercise to budgeting apps, gadgets like the Apple Watch and Fitbit, and budgeting apps like Mint are the most downloaded and used apps. But what makes these gadgets and apps so popular and loved? Well, one, they're automated. They track your exercise and financial activity automatically without requiring your input. Two, they're timely. Data is collected and presented in real time so that you can make changes and see the results of those changes almost immediately. And three, they're accessible. Your data is available to you whenever you want, and it comes in a very slick user interface. Furthermore, they're interactive. The apps offer personal coaching depending on your performance. So because of apps like these and advances in technology, we've become a very data-hungry and data-driven culture. People love to see and interact with their data, and they use this data to influence their behavior. Now here's audit and feedback in the medical world. This is an email sent every 2 weeks to UCSF internal medicine teaching teams that shows their performance on various metrics, including medication reconciliation, phlebotomy, and discharge metrics. Now let's compare this to the budgeting and exercise apps. One, it's not automated. This report is manually compiled and distributed. Two, it's not timely. Physicians often get this report after they've rotated off service, so they can't really act on this data. And 3, it's not accessible. We often, we don't have access to this report until it's sent to us, and it can be a little bit cumbersome to interpret. So, furthermore, it's passive. Teams receive this email, but we're not sure what they do with it. So it should come as no surprise that audit and feedback is not very effective in the medical world. A Cochrane review of over 100 studies of audit and feedback showed that the effects were small to moderate. Furthermore, most of the studies were done in the outpatient setting, and the few that were done in the inpatient setting, which matters to us hospitalists, showed little to no benefit. There's really no consensus on the most effective method. So our team at UCSF are avid users of exercise and budgeting apps, and we're aware of the potential of audit and feedback, but how do we translate the success of real-world audit and feedback to the medical world? Well, first it starts with reimagining audit and feedback. Based on our own literature review and our experience with the apps, we developed a framework for successful audit and feedback. 1, it should be automated. Audit and feedback should capture and analyze the workflow done by physicians without requiring any extra input. 2, it should be timely. Feedback should be frequent enough to be actionable, and those changes should be reflected almost immediately. And 3, it should be convenient. It should be accessible. Physicians should have easy and convenient access to their data, and it should come in a user-friendly interface. So I like to call this audit and feedback framework the Feedback Triforce, for any of you Legend of Zelda fans out there. But we didn't think that just improving the technology of audit and feedback would lead to sustainable change. We wanted to have physicians engage and interact with their data. In other words, we wanted to create a culture around data feedback. We wanted a culture where physicians sought out and valued their data and used this to improve their performance. We believe that this was the key to unlocking the full potential of audit and feedback and to leading to sustainable change. So how do we go about making this feedback Triforce a reality? Well, first, we wanted to improve the technology behind data feedback. So last year at Hospital Medicine 2015, Victoria Valencia, one of our study members, presented an innovations plenary where she described the programming behind linking our electronic medical record, which is Epic, to our scheduling system, Amion, to create a feedback system that was accurate, team-based, timely, and clear. She also revealed an early version of our divisional dashboard, so since last year, we've made great progress on this dashboard. And here's the front page of our current version of our dashboard. So it was developed with the 3 tenets of the feedback Triforce in mind. 1, it's automated. It automatically captures, analyzes, and displays performance data in graphical format. 2, it's timely. It presents data in real time and reflects behavior change immediately. Here we see daily performance in graphical form of our composite discharge metric, which includes medication reconciliation, a discharge summary done in 24 hours, and high-quality discharge instructions, otherwise known as AVS. Performance is measured by the percent of patients where all 3 metrics are met. Here, teams can actually click on each day's performance and get a breakdown of their performance from that day, where they will also see hyperlinks that take them into our Epic EMR and that chart so that they can correct any deficiencies. This is data that is actionable. The dashboard is also very accessible. Teams can access the dashboard at any time to view their data at their convenience. And furthermore, it has an intuitive user interface. This is data visualization called Close the Rings, which shows performance on the various metrics as incomplete circles. Teams can figure out where they're most deficient in their performance, and in this case it would be the high-quality discharge instructions, and can thus target their efforts towards improving that. So we developed this dashboard, which we're very proud of. It's automated, it's timely, it's accessible. But like I said earlier, we didn't think that this would be enough to lead to sustainable change. We want to create a culture around engaging and interacting with the data. And so we created stat rounds. Stat rounds are scheduled group data review sessions that occur once weekly and are with the entire internal medicine teams. This includes attending physicians, residents, and interns. We developed stat rounds. We put a lot of thought into developing stat rounds. We wanted to make them easily integrated into the team's workflow, but we also wanted to respect the team's time and busyness. Thus, we have them occur right after noon conference so that the team just has to stay put to participate in stat rounds. And also, we limit the time to 10 minutes maximum. Stat rounds are facilitated by one of our study team members, here it's Alvin Rajkumar, who reviews the data of the dashboard, which is projected on the big screen. So stat rounds provides a forum to review and relearn metrics, especially low-performing ones. For example, we can use the close the ring section to determine which metrics teams are performing the worst on, in this case, the high-quality AVS, and that way we can target our feedback interventions towards those metrics as a form of academic detailing. StatRuns also allows us to review overall and individual team performance. There was a section of the dashboard that I didn't show called the team ranking section, which shows teams' performance on the composite metric compared to each other. This allows us to tap into friendly competition and also adds a gaming element to data feedback. But what it also does is it allows us to highlight the high-performing teams and have them share their advice and tips to lower-performing teams. This creates a culture, this fosters an environment of peer-to-peer support and coaching. So we implemented stat rounds about 1 month ago, and what we found so far is that teams are excited to see and discuss their data. Teams are motivated to improve their performance, especially when they see their team rankings. And in addition, the high-performing teams are proud of their performance, and they're enthusiastic to teach other teams. And this is what excites us, because these are the seeds of culture change towards teams discussing, interacting, and engaging their data, and using it to improve their performance. We call this combination of stat rounds plus the dashboard the feedback bundle. And although we were pretty confident that the feedback bundle would be a powerful tool to affect change, we didn't want to just assume that. We decided to put it to the ultimate test, a randomized controlled trial. The data trial is a cluster randomized controlled trial taking place over 3 months on the internal medicine teaching service. Half the teams are randomized to the intervention arm, where they will get the feedback bundle, while the other half is randomized to the control arm, where they'll get usual feedback, which is that email that I showed you earlier that reflects the same discharge metrics. The outcomes that we'll be focusing on are performance on the composite discharge metric, as well as MD satisfaction. We're surveying physicians at baseline and every month to understand their satisfaction with the feedback bundle, as well as their perceptions of its efficacy. The trial started last month, so we don't have, so I can't show you official data right now, but we do have some telling screenshots. This is the dashboard for Team C, which is in the intervention arm, and this is their performance prior to the trial starting, when they're still getting the usual feedback. As you can see, they're attaining a 27% on their composite discharge score, which means they achieve 27% of the patients get all 3 of the discharge metrics met. This is the performance with 1 week into the trial, and you can see that it's slowly improving. And here is the performance 3 weeks into the trial. They have met 100% of the discharge metrics on 100% of their patients over the past 2 weeks. This excites us and makes us very optimistic about the potential of the feedback bundle. So in conclusion, we can learn a lot from audit and feedback in the outpatient world, in the real world, such as creating a system that's automated, timely, and accessible. But at the core of this is inspiring a culture that engages and interacts with their feedback, because we believe that this is the key to affecting long and sustaining change. Thank you.
So I'd like to welcome questions from the audience. Can you,
Okay.
you're on stage,
It's
right?
just me.
Introduce
All
you.
right.
Yes, no.
Kevin O'Leary from Chicago. This is great. Thank you very much. One of the challenges that we've had in putting together something similar is the attribution of different quality measures to physicians, let alone a division or a residency program. Many of the measures that we look at in quality are attributable to the system, or multiple professionals in the system influence the metric. So aside from discharge, summary, and MedRec, can you give us some example of some other measures that are on the dashboard that are attributable to physicians and they can change the behavior with the audit and feedback?
Absolutely, that's a great question. So something that I didn't get to talk about, but I'm glad that you asked this question so I can address it, is choosing the metrics themselves. So the way that we chose the metrics that went into our pilot trial right here is that we wanted metrics that were accepted as best practice. The discharge metrics that we chose were chosen by the QI leadership and also the residency. They're applicable to almost all patients. They're actionable in that anyone on the team can do it and they'll be reflected. And also they're automated. But other metrics that we're looking at that I didn't get to show are telemetry use, as well as discharge by noon, which we know that the team can achieve, the team would be responsible for that, as well as lab use. Phlebotomy sticks is another one that we're looking at for average sticks per patient per day. So sticking to that framework, we're able to pick discharge metrics that would fit into the dashboard. But that's a great point in that there will likely be other metrics that we'll have to figure out if they fit into this particular metric.
Great, thank you.
On stage left.
Yeah, a great study. I'm Suresh Panada from Virginia. Quick question. I think you had this improvement in 2 weeks, great change. But did you see that it's been consistent over, X number of time or with different number of groups?
Yeah, thank you for asking that question. So the trial started last month. So this is a work in progress, but that was data that you saw from 2 weeks ago. So what we have seen, though, since then, so we've had 2 more sessions of stat rounds, we have seen sustained change, and overall, all the teams are performing better. So we're optimistic, but it'll remain to be seen. In about 3 months, we'll be releasing the official data.
Okay, thanks.
Thank you.
Stage right.
Thank you. John Lurie from Dartmouth. I'm interested in your AVS measure, and I'm wondering how you determined whether the discharge instructions were high quality or not.
That's a great question. So the way that we've decided that the AVS is the after visit summary, and it's part of our discharge instructions. And the way that it's determined to be high quality is if it has follow-up information in the follow-up section, if there are patient instructions that are handwritten by the team, and also if it has a principal diagnosis.
And that assessment is automated?
That is automated, right.
On my left.
Ethan Cooperman, University of Iowa, longtime Legend of Zelda fan. When I was looking at your data slides, I saw that there were pretty small daily ends for the individual teams and very uniform high levels of performance after only a short time in your implementation. Have you thought about changing your long-term sustainability model to look at the data maybe more infrequently or incorporate additional measures?
So to look at the data more infrequently, I'm sorry?
Because you've only got, and forgive me, the numbers are very small and my prescription needs updating, but it seemed like there were only a handful of cases per day for Team C, for instance.
Right.
If you're only looking at individual events and the likelihood of success on the measure is very, very high, would looking at them weekly or even less frequently than weekly be more appropriate for a longer-term implementation?
Yeah, absolutely. So that's a great question. So are we going to be looking at more infrequently to see if there's sustainable change, since it seems like the likelihood of success is pretty high? Am I interpreting your question correctly? I'm sorry.
More interested, it seems like right now it requires sort of a daily intervention by either a research partner or a fairly high-level person interested in the procedure.
Right.
Is that the plan to continue that indefinitely, or are you looking at something maybe more internal to the actual structure of the teams and the way that the medicine is practiced?
Right, so you're right. So these data are very actionable. We could change on a daily basis. We are doing the intervention, though, on a weekly basis, the stat rounds. It's not done daily. So teams are sustaining their performance despite getting only feedback on that once a week. And we do encourage them to look outside of it. But other metrics that we're looking at that could maybe reflect over time would be things like lab use per day, which the team can change their lab ordering patterns. Discharge by noon is sort of a daily thing as well. But yeah, I think since it's still a work in progress, we're not really sure about, I don't know if I can completely answer that right now. But it's certainly something we're looking into in terms of incorporating different metrics and which ones would be sustainable.
Thank you.
We have time for one more question on the left.
Hi, Erin Caldwell, Christiansburg, Virginia.
Hi.
We use Epic too, and our issue comes with the MedRec, that it gets signed off as reviewed when it actually hasn't been reviewed. So is that something, do you guys have any tricks or, for making sure when you're doing the discharge summary that the person who's discharging the patient may not have been the person who admitted them, to make sure that this MedRec is actually accurate?
Yeah, that's a great question. That's certainly a measure that we are also having issues with, and well, we had issues with, and the way that we reconciled this is we have a metric called prior to admission, or PTA MedRec, which means that the MedRec, as it's updated through as you know, patients, their MedRecs and their home medications are updated through their hospitalization. So we have a way that it tells the teams, as a column, as one of the lists, that the MedRec has been updated, and teams have to go back into their prior to admission meds, review them, and choose to order them or not. But this is certainly a metric that we've been working on. I'm not familiar with the exact technology behind it, as I'm not a clinical informaticist, but we do have, and I can defer you to Alvin and Victoria, but we have figured out a way that if teams review it and choose if they're going to order or not order it, the MedRec metric is met. Does that make sense?
Yeah, I mean, obviously the metric is met, but that doesn't necessarily mean that the MedRec was actually done appropriately with the patient. You're kind of depending on the nurse or the ED pharmacist or...
You're correct. So inaccurate MedRec, is that what you're alluding to? Yeah, that's a great point. This metric just says it's met and it's done, but we're putting the onus on the team, and we're hoping that the team is doing it accurately. And that's something that we just can't measure automatically if it's accurate or not. That's a great question.
Thank you, Dr. Patel.
Thank you.
I'd like to introduce our final speaker for today's RIV plenaries, who is Justin Glasgow, who will be talking about the impact of hospice workload on the utilization of imaging and consultants.
Good morning, everyone. Thanks for coming out. So as we've heard throughout the day of conference so far, the role of hospice in value-based medicine has been increasing, but there has been little understanding of how our individual workload is impacting our care. A recent study that came out from our group started to look at this question by examining the relationship between a census of a hospitalist and the length of stay that they observed. On this chart here, we see that as the census increases, the observed length of stay for patients increased as well. This chart here is when our hospital is at 75 to 85% occupancy, and the relationship varies a little bit with hospital occupancy, but the overall story of this increase in length of stay as a hospital census increases over 15 held across all occupancy levels. Along with this, we saw a similar increase in costs for that hospitalization, and these costs are adjusted for the length of stay. So the observed increase in cost is above and beyond what you would expect just for having an increase in the length of stay. At the same time as we were doing this data, there was a survey that came out showing that approximately 1 in 5 hospitalists feels that they order more imaging and consults when they feel overworked and are unable to spend the time they want for clinical reasoning. And so with that question, we wanted to follow up our study and ask, how do practice patterns change for hospitalists as their census changes? And we had 2 hypotheses. First being that as patients' panel size increases, hospitalists will order more imaging studies, and then secondly, they will order more subspecialty consults. And I seem to have, there we go. So the setting for this study is a single hospital system that represents 2 hospitals, one of which is a level 1 trauma center. At the time of the study, it was about a 1,000-bed system with 55,000 annual admissions. Non-surgical admissions were handled by 3 separate hospitalist groups, as well as some direct admissions to cardiology and hematology. We are going to focus on a single hospitalist group that at the time had 30 providers, primarily physicians, but a couple nurse practitioners as well. The data here is retrospective cohort covering 4 years from 2008 to 2011, and all of the patients are adult patients directly admitted to a hospitalist and discharged by the hospitalist group. We did not include patients who were directly admitted to observation status, to an ICU, or were transferred in from an outside hospital. The outcomes of interest are going to be limited to 5 common disease diagnoses that I'll focus on the next group. And then within each of those diagnoses, we tried to identify relevant imaging tests that may help with clinical reasoning but may not always be necessary for clinical care, as well as relevant specialty consults. So walking through the center of this chart are the 5 common diagnoses that we focused on: pneumonia, COPD, syncope, acute kidney injury, and heart failure. In the first column, we see the imaging studies that were paired with each disease condition. So in the center for syncope, you see that we looked at head CT, head and neck MRI, carotid ultrasound, and an echocardiogram. On the far side of the table, you then see which consults were considered. For every disease condition, we looked at whether any consult was ordered for the patient, and then as well as whether there was a disease-specific consult. In the case of syncope, we looked for whether there was a cardiology consult or a neurology consult. The variables in our model for exposure, we wanted to look at the average hospitalist workload over the patient's hospitalization. And for this study, we defined hospitalist workload as the number of billed encounters per calendar day. So this was basically a simple count of the patient census. Covariates for the model included patient demographics, age, sex, race, and insurance status, some hospitalization characteristics, whether they were admitted to a teaching team or if the hospitalization represented a 30-day readmission, and then given the prior findings of small changes in the relationship based on hospital occupancy, we adjusted for hospital occupancy. The model here was a logistic regression predicting the odds of imaging or consult with increased physician workload. We did separate models for each of the imaging tests and consultants. And very simply looking at it, we're here predicting the odds of an outcome, whether imaging or consult was ordered, based on physician workload with adjustment for the covariates that we went through. And just a quick refresher on odds ratio, values less than 1 signify a decreased likelihood of having the outcome, while an odds ratio greater than 1 signifies an increased likelihood. So now for our results. Starting with the imaging, in total we had 10 imaging studies that we examined. We found that 4 of them had statistically significant associations. They had a 15 to 25% decrease in the likelihood that they would receive the imaging study as patient workload increased. And so what we find here is our significant findings in syncope were head and neck MRI and carotid ultrasound with an odds ratio of 0.85 or a 15% decrease in odds. In acute kidney injury, we found significant finding for abdominal ultrasound and for heart failure associated with echocardiogram. Moving on to consults, there were a total of 11 consult categories that we examined, 5 of which were found to be statistically significant. And in this case, the odds were increased 13 to 35%. For pneumonia, we found an increase in both ID consultations as well as the likelihood of receiving any consultation. In syncope, the likelihood of receiving any consultation. For acute kidney injury, the likelihood increased for a nephrology consultation, and for heart failure, any consultation. This is an observational study. It was a retrospective cohort, so we cannot show certainly any causation here. Overall, as you may have picked out from the tables, there's a small number of cases in each disease category ranging from about 500 to 1,500. These results are not directly linked to perhaps meaningful patient outcomes or to the cost for the hospitalization, and unfortunately we're unable to attribute the orders to the specific provider. So I can't necessarily say whether when imaging studies were ordered, was that ordered by the hospitalist, was it ordered by their consulting subspecialist, was it ordered in the ED before a hospitalist even saw them. What we have found here, though, is that across the 5 medical conditions that we looked at, we did find, as we expected, an increased odds that as workload increased for a hospitalist, they were more likely to call in a subspecialist to assist in patient care. However, there was a surprising decreased odds in the likelihood that additional imaging studies would be found. Taken together with the original study that I presented at the beginning, this certainly paints a picture that workload has an impact on practice patterns of hospitalists and that it is driving length of stay, hospitalization costs, and in some way it is impacting our utilization. However, we've got this counterintuitive finding based on what surveys would have expected, in that we aren't seeing increased imaging as a reflex when you feel busy, but instead decreased imaging. And there are certainly many hypotheses, but I think one thing that is interesting to ponder in our choosing wisely and value-based world is, are some of the imaging tests that hospitalists are ordering in decreased workload without a subspecialist on board perhaps unnecessary imaging? That either from lack of exposure, although these are very common conditions, we should see them all the time. Do we not have the clinical certainty to go without an imaging study where a consultant on board feels comfortable with the diagnosis in the care plan? So in conclusion, we found, as expected, an increase in consults, but that decrease in the number of imaging studies ordered as physician workload increased. Given that this is a retrospective cohort observational study, certainly it starts to build some evidence that our workload impacts our care, but we really need better, more prospective and perhaps randomized studies to better understand the relationship between physician workload and the practice patterns that we take. I'd like to briefly acknowledge my collaborators, Dr. Elliott and Dr. Colm, as well as Dr. Joanna Bryce, who was instrumental in the development of the initial data set. I'll take any questions. Thank you.
All right, we'll start with stage right.
Hi, thank you. Very nice study. I'm Sanjay Agarwal from Mountain View, California. Did you see a correlation about how many number of patients each hospitalist was carrying when these numbers increased or decreased?
The census ranged anywhere from 12 to about 18 to 20. It generally does fall in that range of a little bit over 15, so somewhere around 16 to 17 was the number of patients they were seeing.
And how long was the shift?
I don't recall for sure how long their shifts were. I believe they were 12-hour shifts.
Thank you.
Hi, Daniel Brotman from Johns Hopkins. Great line of research and great study. One of the challenges that we've faced in looking at data of this sort is the question of reverse causation, in that if you have more complicated patients, they tend to accumulate on your service, and you're going to have a busier workday in terms of number of patient encounters because you weren't able to get them out of the hospital because of their complexity or long length of stay. Do you have any tricks that you've been able to devise to try to get at that reverse causation and take it out of the equation when you're painting these relationships?
We don't have any tricks in this data, and it kind of speaks to some of the benefit of the prior presentations with the real-time audit and feedback that, you know, it was a great effort on Dr. Bryce's part to pull together this data set, and the data is increasingly old. I mean, we're almost approaching the 5-year anniversary from the last date of this data, and so we need to be able to get this data in more real time to be looking at it so that you can get better adjustments for actual patient acuity rather than just looking at diagnosis codes, which a number of studies have shown as really a poor adjustment for how acute they are.
Thank you.
Mohammed Murad, IU Health, Indiana. Thank you so much for the great work. You guys give it a lot of thought. I have 2 points here. Why did you look at the imaging and asking consultants or consulting what we did not look at the length of stay index, readmission rate, and ICU transfers?
Mm-hmm.
My concern with the increased workload is that we will miss some standards of care, or get complications rather than get more consultants or get more imaging. Thank you.
So this is the exact same data presented in the initial 2 slides. So the length of stay that was observed there holds here, which is why we didn't repeat that study. The study did also go into readmissions and mortality, in which case they didn't show any relationships at that time. And I think we do agree that more of the expectation is that things would be forgotten, and that would be the reason for kind of throwing a smattering of tests and consultants at a patient to make sure that nothing gets forgotten. So it's what we find so intriguing that actually we didn't see this increase in imaging.
Thank you.
One more question.
Yes, Jeff Stork from Kaiser San Diego. I had a question about the inverse relationship between consultant usage and test usage. Is it possible that the consultants actually were choosing more wisely and the hospitalists were leaving it up to them to order the studies? And was there a subset analysis of who actually ordered the tests?
Yeah, our goal had been able to try and have the test tied to the specific physician who ordered it, but given the age of the data, we were unable to extract that from the EMR to make that connection. I do share that thought that this may represent that the consultants were choosing more wisely than our hospitalists were, in that it is very standard in our system that if a hospitalist is bringing a consultant on board, they would hold off on ordering that relevant test to that consultant until that consultant gave their say as to whether it should be done. Of course, there's a lot that goes unmeasured in this that may bear out to be the actual explanation, but it is definitely interesting to think that this may be consultants choosing wisely.
Thank you.
Thank you.
So that concludes this morning's RIV plenaries. At 8:45, in a few minutes, the rest of this morning's session will go. So you have time for a break. Few reminders. Again, if you liked what you saw here on the podium, come to the oral research and innovations abstracts in room 17A that will be running all day. And to look at the specific presentations, check out your HM16 app. Tweet and have a great meeting. Thank you.